And good morning, everybody. Welcome to the Trust Board meeting of AWP. This is a meeting in public, not a public meeting. First of all, I'd like to ask for any apologies for the meeting today.
Yes, so we have apologies from Emma Wharton-Love and Paul Coombs, who are two of our non-executive directors.
Thank you. And I'd like to welcome those that are observing on camera today. In terms of declarations of interest, are there any declarations of interest for any items that appear on the agenda today? No? Okay. Are there any written questions? Have we received any written questions for the board?
We've had no questions submitted for this meeting.
Thank you. Can we then go through the minutes of the previous meeting, please? The previous meeting was held on the 5th of March. And you've got the minutes in front of you. Are there any amendments that any members have noted in terms of the minutes? No? No? So we're taking them as an accurate reflection of the minutes of the meeting. Thank you, and they will be signed off. Can we now move to the action log and take us through the action log? I will call on persons in relation to the actions that are associated with the individuals. So, first of all then, can we just go through patient story first of all? See that item is closed. So it was Deputy Finance, the Director of Finance and Deputy Chief Executive. Any comments for that item at all?
No, we've done the work outside, and it says the update says we're continuing to do that. It's part of our business as usual now, Jan.
Thank you. The next item was the Executive Board report. I see we've got that in the pack today.
I was going to say, so Gary, Associate Director of Communications, very kindly done something for us which we'll trial this time, and as always, we'll take feedback and improve as we go.
So that item is now closed. Mental Health Committee Chair's report. That item is closed in relation to the committee chairs. The next item was the Integrated Quality Performance Report. That was due today. And it was referred to the Quality and Safety Committee.
And there was a discussion held at the Quality and Safety Committee, and we agreed in Quality and Safety that it was not helpful to report level of harm in terms of sexual safety, because this was the perceived level of harm by the individual, a member of staff, and in a sense it would be inappropriate and disrespectful to look at it in that context.
Thanks, Ina. So we're closing that item. And the final item in the action log was the PCF Committee Chair's report.
Yeah, and just the staff survey came to board part 2 last time and is now published on our website.
Excellent, thank you, Julian. Were there any matters that are not recorded on the action log that you feel that we may have missed? No? No. Okay then. Thank you. And we'll now then move on to the AC unit.
Yeah, thank you, Claire. I'm going to take the paper as read, but just do a bit of storytelling around the AC unit, just so that we've got the full picture here. As you recall, we made a business decision in December of this year that the financial sustainability of the unit was no longer viable, and we received an awful lot of feedback from both service users, the community and staff, and we then made a further decision to do a period of engagement to really assess the feedback and to really assess the community's response to that decision. And we decided to extend the contract before the end of the contract currently, which was going to be March 2025 to June 2025. You will see in the paper that there's some background information about the unit. The commissioning arrangements, which is 3.8 beds, are commissioned by Bristol City Council. And the South West Consortium is a combination of North Somerset, South Gloucester, Bristol and Barnsley local authorities also commission 1 bed. The unit to be viable really needs at least an 85% occupancy, and for the last 10 years that occupancy rate has diminished from a 90% down to a 45%. And there has been a number of attempts to, if you like, reinvigorate the use of the OC unit, with marketing, business managers coming on board to try and increase the diversity of the unit and also the use of the unit. And unfortunately, those did not achieve the utilisation that was needed. Working with our Public Health Director for Bristol City Council, we've looked at the opportunities to do more, and that's still not there. And as they have recently procured the community offer under Horizons, with Turning Point taking the lead provider role, there's been joint work to then take this message to our community and to really listen to what they told us. And you will see in the paper there are a significant number of people who have been engaged with, from current service users, past service users, members specifically. I want to thank the Save the NHS AC Unit lobbying group, who are a mixture of community, past service users and staff, because they have been persistent, tenacious, passionate about the services that ASA provide. But also I'd like to say they've been very respectful and they've listened without changing their viewpoint. I appreciate that, but they have been very respectful. So I just wanted to acknowledge that. And to be fair to them, they also attended the HOSC, which we recently met as well, where they also shared their passion, and this was well received within the HOSC setting. We looked at a number of assessments for the unit and a number of options for the unit that you can see there, but our assessments were based on quality, finance, workforce, and we also did an equality impact assessment. And as you will see in the paper, whilst there are some challenges, the financial sustainability remains a big issue, particularly in our current climate, which is not funded to produce a sustainable position. I won't go through the detail, you've got that there, and as this is a public meeting, those papers are available for people to see.
Can I just quickly ask you to explain what HOSC is?
Oh yes, sorry. Bristol City Council Health and Oversight Scrutiny Committee. Apologies. Our engagement process lasted 3 months, as well as meeting with people in person. There's also an opportunity to meet online, so we did a hybrid offer. And in addition to that, there was a new website to enable people to feedback if they wanted to do that anonymously or not in person. And all of that engagement is included in the paper. There are some key things which I will speak to in a moment, but it's also important to note that our statutory bodies, both NHS South West, BNSSG, ICB Board, and the Bristol City Council Health and Scrutiny Committee were engaged in this process too, and we took feedback from all of them, and you will see some of that within the paper, which supports our actions, supports our direction of travel. But I think it's fair to say the engagement is quite strong in its themes, that they're really concerned about supporting the people, not just of Bristol, but in the South West, the current service users and the past service users, staff particularly, and there was a lot of interest about what the model of care would be in the future and around how they could engage in a more meaningful way, which we resolved as we went along. Both Gary, Stephen and I have been very responsive to questions we received, and we've always responded promptly and as fully as we can without avoiding the issues that we face, but trying to be as direct and as quick as possible in our responses. I think it's fair to say that there was concern about the loss of ASA, and particularly as a new model of care was coming in, and the Director of Public Health, Christina Gray, has been very supportive and is now talking about the smooth transition for those service users, the completion of treatment for those who are currently within the service, as well as a new model which will provide inpatient care with Turning Point support, and also the opportunity to enhance the community offer. And that's now, as public statement was included We did a three-way conversation at the Health and Oversight Scrutiny Committee of Bristol City Council, and they've continued to come forward with that, what that offer will look like, and we'll see more of that coming from Director of Public Health as we go forward. We've met with staff repeatedly in support of them, and we just want to thank the staff for their continuation of the service, for their support for their patients, and for those service users who offer peer support, but also who continue to be engaged and interested in the service, but also their willingness to understand the reasons why we're doing this. And expect most of those staff to be redeployed where possible. There'll be some individual decisions that individuals will make, but they are working with our HR colleagues to what the opportunities may be. And our decision today will then allow them to go through a formal process. In terms of other feedback we received, there was some feedback that related to the model of care, feedback that related to the transition, and feedback that related to other opportunities with a combination of physical health care and detoxification support. And that has been fed back to our Director of Public Health, so they will take that forward as part of their offer going forward with the New Horizons model. We're being asked today to consider the next steps for ASA. We're being asked to hear the engagement as it's written and as I've articulated. And we've also been asked, because I've made the recommendation that we do close the unit due to the financial challenges the unit faces, and it's not sustainable. And also to be very clear that we will inform the staff. I have a meeting planned with them tomorrow, and we will inform the staff, but they'll also get a statement this afternoon, depending on our decisions, so they will be updated, and we can continue then with the formal processes to support them. But in addition to that, I think we have some lessons to learn from this process, so we've committed to provide a report on the lessons learned from this process once we've completed our decision today. And that closes my storytelling. I'm very happy to answer questions.
Thank you, Alison. I'm looking for questions. Brian, first.
Yeah, thanks, Alison. For me, this is a well thought out and a very clear paper. Can I just seek some clarification around paragraph 41 for those that haven't got papers in front of them? This is the feedback from the engagement process around the impact on the individual, pointing out that a move to community detox may not be appropriate and provision of ongoing inpatient care in other locations. You're asking us to take the decision based on the engagement which has picked up issues around equality of staff training and particularly the model of care. And I just ask how those things that have come back from the engagement process are going to be followed through into this pathway review through the likely people involved in that, bearing in mind it's probably wider than AWP.
Yeah.
And if our commissioners and colleagues have any idea about timing as part of that decision. Thank you.
Absolutely. No, it's a really good question. Thank you, Brian. So the Director of Public Health and the Clinical Lead for Turning Point have received the feedback, and they are absolutely committed to enhancing the community offer, and that does include some training and development. And of course, they're bringing in other partners from its license, because there are many partners, both third sector and volunteers who support alcohol and drug detoxification in the community. There will be a need for some patients to still go to inpatient care, and Turning Point have the perfect opportunity to identify the most appropriate for the individuals who are in front of them. They will support the training and development of staff, and we of course are supporting them with our staff, because we also had a community offer that have transitioned over.
Yeah.
And so that continuation and safe transition is paramount, and we're fully committed to do that with the Director of Public Health, with Turning Point and the other partners involved in the Horizons offer.
Okay, that's very clear. Thank you.
Paul.
Yeah, just a quick question. As Chair of Finance Committee, can I just clarify whether this proposed decision is reflected already in our financial plan?
Thank you for the question, Paul. So no, because we didn't want to prejudge the outcome of the engagement. So we've done our operational and financial planning without including this. If we do ultimately take the decision today to close the year, then we'll have to adjust our plans and then represent those to Finance Committee in due course.
Right, thank you.
Sarah.
Thank you, Chair. So I discussed this paper with our strategic expert by experience group that contains both service users and carers. And there were a couple of points that they were keen to bring into the board. The first was a discussion around, as you've already mentioned, Alison, what the provision would be. So what would be the alternative provision? And I think you've already covered that in your summary there, Alison. So thank you for that. And the other question that they were keen to ask was for service users who are using our core mental health, acute PQ and other units who require a detox during their admission, would we be able to support that? And I was able to reassure the experts by experience that we do that currently and we will continue to do that. Thank you.
Alison.
There's just one final comment I'd like to make on the paper, please. At the top of page 19, in the financial impact assessment, where we've assessed what impact there would be by closing the unit. I don't think the language used in that box is quite clear enough, so I would like to make an amendment to that to address that, so we're very plain in our language before this gets shared with the minutes, if that's okay, Chair. And that's just to really clarify that closing the units because of the current loss will have an impact in this financial year for us. But there will be a positive impact in terms of the run rate. So I just want to make that clearer rather than leave it as it is, if that's okay.
Yeah, that's fine. Thank you. Any other questions? No? And so we are asked as a board to consider the engagement process that has taken place, and how those themes have been used and captured in the paper, so but used to inform the decision in relation to the future of AC unit. We're then asked, or it is recommended, that we consider the option to close unit, option 4 of the paper. There are two other caveats in this in the recommendations. One is around following the decision, how staff will be supported and informed and supported and consultation process. And finally, we're asked to note that lessons will be learned in relation to the way that we've managed this process and inculcated into the way that we do business in the future. So in relation to those recommendations, particularly the engagement process, can I start with that? First of all, are we in agreement with the way that the engagement process has taken place and the themes reflected in the paper?
Yeah, seems like
Absolutely.
Yeah. Okay.
Yes.
The second recommendation, the recommended option 4, to close the AC unit based on predicated on the information that we have seen in the evidence that we've seen in the paper.
Yeah.
Yeah. Thank you. The third, clearly, the informing and supporting staff, supporting through the informal consultation or formal consultation process in the future. We will, as a board, note and expect that to happen. And finally, in relation to lessons learned as to how we manage this process and take those improvements into any process that we have to move forward in the future, are we in agreement with that?
Yes.
Yes.
And thank you. On that note, we will then close this item. Thank you, Alison. I did just want to add, although I've closed the item, a special thanks. I'm just reiterating, I think from the board, a special thanks to the staff, particularly those from the AC unit and the state of the AC unit who have been respectful, but equally raised their voices and ensured that they were heard and that they were considered in this process. I would like to extend special thanks to them on behalf of the board. Okay? Thank you. Can we now then move on to the next paper, which is the Executive Board report, please? And Dominic, I'd like to hand that over to you.
Thank you, Chair. So the executive, the executive board report is obviously included in the papers. Yeah, I think it's largely self-explanatory. It describes the business that we undertaken in the executive board, what we reviewed, decided, agreed, and assured ourselves around, and then what's come forward up to the board. There aren't any particular things that I think are noteworthy, worth highlighting. Having we not just had the conversation about ACER, I probably would have highlighted that, but we've now had that conversation. So I think it's principally here just to provide information for, but assure the board that this is the main business that we're doing within the executive team in a given month. So I'm happy to take comments and questions on any items contained therein.
Thank you. Oh,
I think just worth calling out and noting, we did this in a committee earlier this week, but the transfer to HCRG and the positive feedback from commissioners in relation to that. I know that was a concern we had a couple of months ago in terms of how that would gone, but unless you tell me otherwise, it appears to have gone well as could have been expected.
Paul, on screen, Paul Miller.
Paul Spencer covered the question I was going to raise on HCRG, so thank you.
Okay, thank you, Paul. Any other questions? Any other comments?
It's a comment rather than a question, but last week's seminar in relation to transformation was really helpful in terms of setting the scene and the path forward over the next few months. Don't know how you feel about this, Dominic, but I'd be really keen to start to shape the savings plan for 26-27 off the back of some of those initiatives, those 3 or 4 initiatives that were described. And it might be that we don't have any numbers against those initiatives in the early months, but I think it just helps us to have a visual on that. So, yeah, leveraging off the back of last week's seminar to start to build next year's plan would be my.
Yes, I mean, I feel like we've only just started this financial year,
Yeah.
but I feel right to have a longer term horizon. So it's duly noted.
Okay, thank you.
Thank you. Noted or reacting?
Well, inevitably we will enact a version of it because that's what we have to do. Clearly, we have to do. Quite what the exact response to the comment will be, I don't know yet because we haven't figured that out yet. So.
Yeah.
Okay, so perhaps we want to bring that up again.
I'll bring it back to. I think I'll talk it through in finance committee, but I'm just envisaging, even if it's just a load of blanks at the moment, that we start to build it cumulatively month on month, so that we don't get to November, December and start to think, what's the plan?
So something that we discussed in FP&P
Yes.
and then brought back if we do think it needs to come back to the board.
If it needs a nudge, yeah.
Yeah, okay, thank you. Thank you, Dominic. This paper is just for us to consider and note content moving forward. Brian.
Just a thought for FP&P, probably not for this morning, but as an accountant, I'd love to know what keenly priced means in terms of the services with HCRG, but I would suggest that's probably better pursued by FPP. Not an accounting term, I remember. And just an observation, if I may, in the appendix, the campaign for BSW talking therapies. I'll say this because he's in the room behind me, but I don't know what's happened differently this time. But this appears to be one of our most successful comms campaigns that I've ever seen. I see it everywhere. I see it in papers, I see it in my blog feeds, I see it on social media, I hear it on BBC local radio. So whatever we've done differently, it is certainly working. So well done to the comms team.
Thank you. Thank you. Paul Miller, please.
I thought about asking this question. I thought I might as well do it actually. under the paper, it talks about the mobilisation of the integrated non-custodial service, and that new service commenced in April 2025. Dominic, could you just give a very brief update on what that is?
Probably not the person best placed to do it, and looking at Matthew to see what you've heard.
Excuse me. Yes, thank you, Paul. This is the services that assess and support people in custody, so people who've been arrested and detained by the police, providing advice and assessment for people in that situation so that they get access to mental health services if they need it.
Okay, and that is somewhere along a pathway to secure services or not?
No, this is a different type of service. So secure services generally deal with people who have been at risk of significant offending or have got a history of significant offending and have had a what's referred to in law as a disposal by the court often, or are already in prison serving a sentence and get transferred. This service is for people who've been arrested by the police. So someone might be arrested for a public order type offence, and as part of the custody process that they would be medically screened, which could then include a more detailed mental assessment of their mental health to see if that's a feature of the incident in order to advise onward management and, if necessary, onward referral into mental health services.
Well, and then the final question, that onward referral could be our PICUs, our psychiatric intensive care units, anywhere in the trust.
It could be, and very often it would be onward referral into parts of our community services as well.
Yeah, thank you.
Thank you. Any other questions?
I just wanted to ask Dominic, do you have any idea of when the national guidance on the Supreme Court ruling will be issued by the NHS?
So no, we don't yet any time frame, and as I'm sure you can imagine, that's something that's been considered carefully at a national level, and there'll be various complex pros and cons of different interpretations. And so, like the rest of the NHS and the public sector in general, we're awaiting further instructions.
Thank you. Any other questions? No? So we're happy, are we happy to accept this paper in relation to noting? Yeah?
Yes.
Okay, thank you. Can we now then move on to the board assurance framework and the risk register update, and I'll hand this over to Alison, the Deputy Chief Executive, to introduce it.
Yeah, many thanks. So this is a regular update that's provided to board to focus on process, not necessarily the individual risk that will be owned by the individuals that who are named in the risk register. What we wanted to identify, and hopefully you will see in the paper, those risks that have moved in terms of their rating and or any new risks. The Lisbon system is just about to crash. And so this paper highlights those. It also highlights the top scoring risks. So our starters, we need to go on through the paper. So the top scoring risks that we've got listed in point 9 on page 31 are those where there's cultural change relating to secure services, ligature reduction, and the demand capacity for ADHD and autism services. These are not new, they are known to us, but it's important to note that they are some of our highest scored risks. You will see other risks identified there, and they are just for noting that the board is asked to receive the report for information, to ask any specific questions they may have about process. And as you're all aware, and I'll just share this, the scrutiny takes place during the committees of those risks that are relevant. So I just wanted to identify that process route, because all of those who are in those committees will be aware of that, but just for the record.
Thank you very much. Thank you. Any questions in relation to insurance framework? Sarah?
Thank you, Chair. Again, just a comment that was raised through our strategic expert by experience group when we discussed this paper on Friday, particularly with respect to the secure services risk. And we talked about the involvement of experts by experience within the service in that culture change work, as has been previously presented to the Quality and Safety Committee. However, the experts by experience also recognise that there is a gap at our strategic level with representatives from secure services, and they were keen that the board was aware of that, and that we will be working with secure services to see how we can support that involvement with the strategic group moving forward.
Thank you. That's a really good move forward in relation to engaging service users. And will you will inform the Quality Committee in relation to how that's progressing?
Absolutely, Chair, yes.
Brilliant, thank you. Anthony.
Sorry, it was remiss of me not to include the BAF, because obviously with the new contractual year, we redeveloped the BAF. And very excitingly, the work with Ulysses, which is our online system, has been progressing under the guidance of Donna and Vicky. And we're hoping within this financial year that we will get our BAF moved from an Excel spreadsheet, which is not the easiest to use, to be honest, onto a portal system. And this has been a long programme, and it's not due to lack of effort. It's just Ulysses having the capacity and the time, and also making it fit for purpose for us, which is very important. And the new board assurance framework for this year, so 25-26, will take into account our strategic objectives as well as the operational plan. So apologies for not including that earlier.
That's okay, thank you. Any other questions for answering in relation to the BAF or the risk register? Paul?
Just a quick question about secure services. I know we talk about this later today, but for the public meeting, what are the mitigations we're putting in place to manage this risk?
Ben, would you like to respond to that, please?
Certainly can. Thank you, Chair. Thank you for the question, Paul. So the risk that we're currently recognising is a cultural one, and we recognise that it takes time to shift the culture within the service. However, during the period that we're working on this, we have a number of increased oversight functions that are working with the service to make sure that the care that is being delivered during that time is safe and is effective. So increased visibility from senior leaders, increased visits to the service, and opportunities for staff and service users to feed back and to raise any concerns that they have within the service. We also have increased quality and safety checks going on within the service as well, and indeed have had executive and non-executive visits to the service in order to monitor that progress, but also to engage with staff at the ward level and service users within the service to understand what their current experiences are and to mitigate that risk.
And a final question. Is there a view from the commissioner of this service as to how we're taking things forward?
Thank you, Chair. I'll take that one again. Yes, there is absolutely. So we met with our stakeholders for our enhanced contractual quality oversight group last week, where we took feedback from the medical director for the South West Provider Collaborative, who is the commissioner for secure services. The feedback that we received very much mirrored our own assessment of the service, in that it is an improving picture. So they have noted improvements in the openness and transparency of the service. They noted improvements in the quality of care being delivered, and they had noted improvements within the culture as well. They have stepped down some of their intensive oversight from some of the wards within secure services to reflect that, and they were assured by the plans that we have in place to continue to improve the culture there.
Thank you.
Thank you, Sarah. Any other questions on the table? No? Okay, so we're asked just to receive this information, this report for information, knowing in the knowledge that we actually will go through this with scrutiny at the supporting subcommittees of the board. Yeah, okay, thank you. Can we move on to quality and safety now, please? And I'm going to ask the chair of the Quality and Safety Committee, Ela, if you'd like to start with your chair's report, please.
So we have two chairs reports here, one for March and one for April. And we are coming in line with the new structure, so you will now receive the reports into this meeting in a timely fashion. Some of the discussions that we've had at Quality and Safety have been very much around the things we've been talking about recently. So in particular, things like secure services, and I know, as Paul said, we have a discussion later on, but increased oversight from Quality and Safety Committee around improvements in secure services around some of the culture of change. The other key issue that we've been looking at is we've now received a report on the Riverside unit, and that is something we considered at the last meeting. And as you can see in the paper, we will bring further information back here, but there is further considerations to be taken based on the Riverside unit, which is the CAMHS inpatient unit that has been closed for a while now. The other piece that I just want to flag through the report is the improving picture of assurance that we are getting through Quality and Safety. So there are further reports that pick up learning from future deaths, etc. And we are looking at other reports that come into this committee. So in the report I highlighted in March that one of our mortality reviews had suggested that there'd been an example of poor care. The medical director fed back to us at the last meeting with the detail of what that was, and it was an issue of recording rather than actually the delivery of poor care. So we were pleased to receive that. In terms of the last meeting, which was in April, we particularly considered the recommendations of the mental health homicide review, and the board will remember this is in relation to the tragic incidents following in Nottingham following a service user's actions there. There is further work to be done in this particular area. We have taken an initial look, and the DCL has been worked through. And in particular, we are compliant with the recommendations, but we are talking to our commissioners in terms of what that might mean in terms of structure of some of our assertive outreach services. And it was really interesting when we had our board seminar last week to see how some of that plays into actually the delivery of care at the front line. I'm happy to take questions.
Thank you. Paul.
I've got a question. It relates to the March report, not the April report, and it's a point of detail, so we may need to take it offline, but it's a point of detail that's informed actually by personal experience 6 years ago. It relates to point 4, and where there was a problem highlighted with information being transferred between providers. So when someone is moved from provider A to provider B, how does that what is the process for that information flowing? Is it a paper trail, or is it a call between psychologists on the unit, or is there an online system that transfers the information? I'm just interested in how we make sure that always happens.
So that's a level of operational detail that I don't have, but we certainly have that discussion in particular in relation to the learning area. I'm going to hand over to Sarah to answer that.
Thanks, Chair. I'll just take you through that. So it's a complicated answer to a simple question. It's a it depends answer. So it depends which service you're talking about to which service. And so if it's an internal transfer, and it's the same electronic record, then it's seamless, because obviously people can access the records. For this particular Regulation 28 report, which is the request from a coroner for additional work to be done to often in a system way. This was related to somebody who was transferred, was known to mental health services, and then was transferred from one prison to another, which means that those records are slightly out with our control, which is why we've had to put in an improvement piece of work rather than it just being a system switch on and off. It isn't possible just to kind of use an electronic system and switch a switch and it all gets transferred, because they're completely different systems. So we've had to put in place some work so that the teams will do that in a proactive but in a manual way to search, because at the moment it's just not possible to do it in a simple way.
And just to follow that through then, because we have quite an issue with out of area and we use Signet and private providers, if we were using a private provider like Signet, is there an automatic transfer of information?
No.
Or do we have to put a method in place to make sure that happens?
Yeah, if we transfer a patient, say, for example, to a different provider who does use a different system, then it is a manual transfer of information, and likewise a manual transfer back.
And how do we make sure that happens?
So if we're doing that transfer, then what happens is there's a clinician to clinician conversation between wherever the person is going to,
yeah.
And then we will provide the information, people who have a key worker, or in old style care coordinator, the care coordinator function will follow that patient, and they will be the point of contact between services.
Thank you.
Thank you. Any other questions or comments? Paul?
A quick question, and it flows from the March report, also a recent hospital visit I did. So I apologise, I might be adding 2 and 2 to make 5 here. But in the March report, we talk about some significant assurance on physical health. But in our recent hospital visit, there were some issues raised about that was basically around physical health and the input that we currently have into some of the physical health on some of our inpatient psychiatric wards. A key part of that as well was the time it takes junior doctors to actually get things organised, which is both a time issue, a resource issue, and potentially a quality issue. So are there any issues around that interface of physical health into our inpatient areas, or are we totally happy with the physical health interface?
Sarah.
I'll start. Sarah may decide to chip in, but as you mentioned, junior doctors, unlike in services from psychiatry into acute physical health, there aren't liaison services as we're familiar with, and so it does depend a little bit service to service, but in terms of access to acute physical health care, any doctor or nurse, but particularly through the doctors, they have access to acute services. So generally what would happen is you would telephone and seek advice for something that you were concerned about. You could make a referral in a routine way. So, but if you're worried about something, then you go through the on-call system and you do get an immediate response, as a GP would in primary care. For some of our services, so for example, down in Salisbury, we do have some GP sessions that come in, and also for our secure services at Froomside, we have a GP clinic that runs from Froomside. So it is a bit variable. Where we do have some issues is we don't always have easy access in all of our areas to ordering investigations, and some of them have to be done in a manual way, which does take a little bit more time. But from my point of view, I would say we do have access to physical health care for our patients when we need it.
Thank you, Sarah. So, do you want to add anything to that?
Sarah's given a fantastic description there, and the only things that I would add would be from a nursing care perspective. So we have done significant amount of work to improve our performance over the last 12 months in terms of ensuring that we undertake the required range of physical health checks when somebody is admitted to one of our units, and our performance in relation to that has increased significantly over the last year, where we are not always quite meeting the target, but we are within a reasonable range of the target, and we continue with that oversight work to make sure that we continue to improve in that area. The other piece of work that we've been doing with the physical health team is increasing the level of training for our staff in more in condition specific, I guess, physical health management in order to better support them to manage the common presentations that they see on a day-to-day basis, and to work in partnership then with our medical staff to manage physical health.
Thank you.
So the only question that I'd have, and it's a reflective question just for you to ponder. Last week we heard about the importance of having some sort of evidence-based approach. So where Sarah talked, the medical director talked about variation, there's warranted variation and there's unwarranted variation. So I suppose the question is, with the variation we have, particularly around the ordering of tests, etc., is that something we're happy with, or is that something we just need to continue our process of improvement and have a consistent high standard approach across the trust?
Thank you. So, you want to respond to that?
Yes, thank you. Thanks, Paul. I think that's a great question. It's about our continuous improvement. And yes, we are endeavouring to continuously improve. As you'll be aware, we work across 2 different ICBs, but also a number of acute providers. So because each acute provider does things slightly differently, we haven't been able to just take a trust-wide approach. I think the important thing is that we're really cognizant of what area does what, so that we don't think we've put in something across that doesn't work. So one of my deputies is leading on this, particularly came about through the GP collective work, and we've continued our work both with our acute colleagues and into primary care to try and reduce the variation. The important thing is that if a doctor is on call and needs to do something, they really need to know what the system is in that area, particularly if you have people who move around. So we're very conscious of that, and we are continuing to monitor it.
Thank you.
Thank you. I am going to draw this section then to a close. We've spent quite a lot of time on the chair's report, so thank you for a really comprehensive, or 2 reports, Stephen, and for the questions that have come forward. Why don't I move on to the freedom to speak up and your report, please?
Of course, Chair, I just want to go and invite the Freedom to Speak Up Guardian to come in to present the report, if that's okay.
Hello, Louise.
Hello.
Hello. Morning. We've got your item on the agenda, and Freedom to Speak Up annual report. I wondered whether you could just draw up some real easy highlights, because we'll have all read the paper, and then we'll open it up to questions. We have 10 minutes for this section, so I am going to try to hold us to that, given that we've got quite a comprehensive agenda.
And I won't talk too much. No, I was only going to pick out just a couple of bits, actually, just to mention about, although I didn't go into a lot of detail about it, on the recommendation about implementing the Learn training for freedom to speak up for staff. That, I think, would be key for the organisation from our perspective of ensuring that staff in the trust know how to speak up in the workplace and in their teams. And I didn't feel there was anything significantly different in some of the data, except that I've included an extra 3 months and made it over a full year in comparison to the previous 12 months. There's not a significant increase in people coming forward. There is a slight increase in corporate services, but that has related particularly to facilities because of all the awareness raising training that we're currently doing with that department. And we have, got some freedom to speak up champions in that team. So that's all I was really going to say, if that's okay.
Wow, that was succinct. Now we'll get up to questions or comments, please. Dominic.
So I'm going to ask the question I always,
Yes.
so you can probably see it coming, which is, as you know, I'm constantly blown away by the work that you and all the other guardians are doing. I think it's amazing, and I think based on my own experience, I think we're an exemplar, and yet we know it's still not enough. And therefore, when you think about where we are now compared with where we are last time you came to see us, where do you think we're at? Do you think we're getting into some of that stuff and we're improving things? Do you think we're in kind of steady state? What's your sense?
Well, I would say that there is an improvement in the culture particularly. I'm using a couple of examples. So number one would be about how I'm being approached by individual staff members to be champions and hearing about it within their teams, wanting to become involved in the process. The way that people are speaking up now is they're coming more about advice, support, guidance to actually escalate their concerns rather than it coming through me per se on their behalf. So I've noticed that. The way we're talking about culture within teams, when I go around and do a lot of the training and awareness, or which champions are doing that, people know about it. I'm not going anywhere now where people don't know about speaking up, what it means. People are less frightened than they used to be. In the last few months, I've had senior managers say, you know, I don't know why I was worried about speaking up. You know, I'm the same age as this person. Why? Because they're a bit more senior than me, that I'm frightened. They were listened to, and then they have a good experience, and that's then carried over. Where there are areas where people there is issues within a team and culture, even now people are wanting us to come in with the HR team as well and develop the team and get to the bottom of what's going on. And the actual team managers themselves have asked, could they become a champion to help with that culture within their team? Those types of things. But the actual, I mean, I've worked in the trust for 20 odd years, so the difference is astronomical from when I first started. I couldn't recognise it, and it's getting better and better. There might be subtle changes, there might not be major things you notice from the report, but the feel of what's happening, it's not perfect, there are still areas, but definitely the culture's improving. And I understand in the staff survey, we had slightly increased with people able to come forward as well and speak up about concerns.
Thank you, Sarah. Thank you, Liz. I've got Sarah, then Eva, and then Paul.
Thank you. I just wanted to ask about, at the end of your assessment of the paper, you've said there are no equality impacts noted. I just wondered if you could just expand, is that because the data isn't collected in that way? I'm just thinking about people with protected characteristics and the differential experiences that they have, whether we are picking up any themes there.
Well, of the people that have come forward, that hasn't been evident at all. But when you say, yeah, you're right, maybe what I need to do is articulate that in my data. How many staff came forward, and you know, but we do have we have a good mix of staff of all diversities and protected characteristics, etc., as champions, but I haven't highlighted that in the report, but that's a significant number. But we haven't noted any problems with people coming forward and wanting someone that they identify with to speak to. That hasn't been an issue. But yeah, I think it would be good to capture that information. Yeah, definitely.
Thank you.
Thank you, Liz. And I think I asked you this question at Quality and Safety, but I want to go back to it because on reading the report and looking at the further information that you put in there, where you find areas that are silent, where there is no speaking up, and you've got it at divisional level, but not team level, what is your approach to just sense checking that people are aware of your services and they know that, do you ever worry when people don't speak up?
I mean, there is lots of other information that we would be collating from a trust perspective about particular areas. Unfortunately, probably at the moment, there have been teams that have been quite silent and they have been exemplary, if you like, and have got really good reputations, practice-wise or whatever. And then something will happen, and then, or you'll hear a rumour. That's, I mean, an intelligence or something minor will come up there, and then that has escalated to a much more serious situation, which is what we have had in some teams. we always try and ensure, like the community is one area where we don't have a lot of champions, but that's increasing now, and really trying to make sure that from our networks with our champions that we are covering a lot of the teams. But you normally get something. It might be through the safeguarding, it might be through nursing and quality, it could be from HR, that there might be something happening, and normally then I would be approached about that. But I can't say that I'm 100% fully aware of every single team. We do our best, and I think what might be needed is an approach to looking at, because a lot of information is collected about everywhere, and putting that information together with mine to get a much better overview of what's happening within a team, I think is needed. I have discussed that with Director of Nursing, Sarah, and that might be something we need to look at, because we do keep all this information, but we don't always put it together.
Thank you. Paul, can I?
Either ask the same question.
Okay, all right. I am going to then draw this section to a close. The recommendation is that we note the report. Now, as it's an annual report, is this report published on our website?
So it goes into the board papers, which are publicly available on our website.
Please, can I take this opportunity for, well, first of all, ask the board to note contents of the report. Secondly, Liz, can I thank you and the champions that we've had today, 144 of them to date.
Probably 147. It just keeps
fluctuating. But thank you all for the work that you're doing, and just put out a plea to the rest of the staff across the organisation that they too consider becoming being to speak up champion.
That would be amazing.
Yeah. But thank you very much for attending.
Pleasure.
And for the work that you continue to do.
And can I thank you all for the support that I've received in the Guardian role, because that makes such a difference in what I've been able to achieve. And that isn't always replicated in other organisations. Just to thank each and every one of you for the fantastic support I've had in my role, which I absolutely love. I don't want to do anything else. Thank you very much. Okay, thank you.
Chair. Paul, did you want to come in? Sorry. Liz.
Yeah, it was just one thing. It was a very good point that Liz made right at the end about triangulated information. And I wouldn't want that to be ignored. So if put up to yourself, Chair, but we might want to reflect that as an action point, just to consider that triangulation. Because in Liz's comment, she talked about pockets and she talked about areas. And in answer to Ela's very good question, she said the same thing. So we have soft intelligence, and it'd be nice to know we're utilising that soft intelligence to identify these pockets, these areas. So an action for me would be quite helpful if you consider that appropriate. I'm not saying what it is, I'm just saying have a think about it.
Yeah, I think that it is appropriate, and I'm going to defer to Sarah Jones, Director of Nursing, because I think it may well be that is triangulation that can be done. I'll speak on your behalf. Can be done and presented through the Quality Committee so that we get the assurance of the board.
No, Chair, I think that's absolutely right. I think the conversation, in fact, that myself and the Director of People had earlier today on our journey into board was very much around continuing the work that we do together across our directorates to ensure that we bring all of the information together around people raising concerns, where they're raising concerns, who to, and how those are managed, and what learning comes from those, and how we can promote that culture of speaking out, not only through the Freedom to Speak Up Guardian route, but also more in terms of the comfort that people have in speaking out within their own teams, being listened and having those ideas or concerns taken seriously. So we will do that collectively.
Thank you. Ron, did you want to?
I think we did, and thank you, Paul Miller, for reminding me. I think we did flag this at the last Quality and Safety meeting when Liz did the Freedom to Speak Up report. We do, I think, need to take it to the next stage, you're right, but we I seem to remember the conversation in Q&S was around how can we triangulate every part of information, both through internal review, such as freedom to speak up, and external review, so we have no surprises, particularly from external regulators. But I think we need to formulate that through, and maybe the action, Paul M, might be to actually formalise something through from quality and safety up to board, for then board to actually reinforce that that's happening and then put it back into quality and safety. I'm also happy to pick it up with our meeting next week.
Next week, yeah.
Liz, in my role as whatever I am. One of my roles on the board, I should explain that last night.
Right, for articulating that, yeah. Thank you for articulating that, and I think it does need a dual lens, and where we can, we need to triangulate. And I'm really pleased that Julian and you are talking, so that we're looking at it from the people perspective, but also from a quality and safety perspective.
Okay, thank you.
Okay, thank you. Thank you, bye.
Bye. Thank you, everybody. I think that was a really good discussion. Okay, can we move on then to the safety effectiveness and speed? Sarah.
Thank you, Chair. I'll just pull out a couple of details because you have the report there, and you have access to the detailed information behind the report in the Board of Tech reading room. So key points from the report, just to note that there has been a slight dip in our performance in terms of our response or our initial triage response to complaints. This has been due to some gaps within the team. We are managing those gaps, and recruitment is underway, and we expect that to improve once those people come into post. We have seen a change in the themes that are coming through complaints. So for the first time, complaints regarding safeguarding and vulnerable adults has entered the top 5 themes. The numbers continue to be low, so only 9 complaints in that category, and no specific team is an outlier, so they are a range across the organisation, but we will keep oversight of that. To offer some assurance to the board where complaints of those type come into the organisation, the PALS and complaints team pass those to the safeguarding team, and they are all dealt with in an appropriate manner to ensure there are no quality and safety issues whilst that complaint is investigated. And I would report to the board as well that reopened complaint rates remain low and in line with our usual numbers at 15% within Q3. Delighted to let the board know that AWP has retained our 2-star accreditation with the Triangle of Care, and I really wanted to draw the board's attention to the feedback that we had as well from the assessors from the Carers Trust, which is in the report. I won't read that out, but I think that that shows the ambition that we have to work more closely with carers, and also the way that we're challenging ourselves in terms of our assessment of whether or not we're meeting those standards. The Friends and Family test, which we're now delivering through our new system, I Want Great Care, is also included in the report with just under 85% positive feedback for us. So in line with, again, our kind of usual rates. You will note that there has been a decrease in the number of people giving us feedback through those routes. And we have asked the question of I Want Great Care as to whether or not that's something that we should expect with the changeover of the system, and they have confirmed that all other providers who've been through that transition have experienced the same drops, and we do expect that to improve and increase as people get used to using the new system. And we had some conversations at our safety effectiveness and experience group around how do we better promote I Want Great Care, and are there more things that we need to do in order to raise awareness of that feedback loop. In terms of patient safety, you will see that incident reporting rates and themes remain aligned to our usual levels. Nothing particularly to report there. However, I am really pleased to let the board know that the issue related to open overdue incidents has improved significantly since the last reporting and continues to improve. So the number of open overdue incidents has decreased by 73%. in the reporting period. So a really good piece of work, and I thank our divisional directors of nursing for their oversight of that and the work that they have done to ensure that the processes within the teams now pick up those incidents early, review them and close them appropriately. But we will continue to monitor that in order to make sure that we don't end up with those creeping up again as they had done previously. We've also been managing our overdue patient safety reviews, or PSRs, during the period, and again they have reduced, particularly in Bristol, where we had a much higher number than elsewhere. And again, the Divisional Director of Nursing for BNSSG area has been working with the central team to set up better processes in order to make sure that that does not happen again. And the last point that I would raise is in relation to duty of candour in this report. So you will note, and it has been reported to the board previously, that we've been doing some work within our Ulysses incident reporting system in order to enable us to better understand our compliance with duty of candour. And we started running reports from that during February this year, which has identified some gaps for us. So we have taken that forward and explored what those issues are with the teams and identified some differences in understanding that have arisen since we've implemented the PSIRF, or the Patient Safety Incident Response Framework, which is a new way of thinking about patient safety incidents. The old serious incident framework looked at levels of harm, and therefore it was very easy to identify when duty of candour and statutory duty of candour applied. The PSIRF process doesn't look so much at a level of harm to indicate where learning might be able to happen, and therefore duty of candour is more difficult to assess. So we will be working with the teams in order to monitor that compliance and improve that compliance as we go forward. So I will pause there, Chair, and take any questions.
Thank you, Susan. Any questions? Thank you.
Thanks for the report. I'm really great around the decrease in overdue, so massive decrease, but there's some increases in areas. Can you just tell us a little bit about, if we're doing such work about bringing them down, what's causing the increase? Is it again the volume coming in, or is it capacity?
So it's basically it's new incidents coming in, and when you get a particular team who perhaps have a number of incidents occurring at any particular time, then that number might increase. So one of the areas that they've increased is health and safety, which is in fact one incident. So we're less concerned about that. Where we were very concerned was in areas where we had very significant numbers of incidents that were we didn't have the assurance that they were being reviewed, and therefore the learning was happening. And we had some incidents, as the board will recall, that have been open for a very significant level of time, which we have now reduced. So those that are open are not open for significant periods of time and are being closed, if not quite in line with the 10-day expectation, much more rapidly than they have been previously. And as I said, there is still work to do in the area, as you can see from the numbers, but it is those areas where there are a lot of incidents or very low level of incidents that it's tricky to quite get right.
Thank you.
Thank you, Susan.
I just wanted to follow on from that because I just want to clarify. So there's a triage process that goes in place as incidents come in to identify what needs to be prioritised based on the number or severity, which I think is really helpful to just clear it up.
Yes, no, absolutely. Thank you.
Thank you.
Sarah, as you know, we looked at this in quality and safety, and I wonder whether you've had the opportunity to talk to the strategic carers group about the triangle of care results and the feedback we've got, because in triangulating this, we wanted to make sure strategic carers group were cognizant of what was being said and how they perceived that as well.
So the answer to that, Ela, is not yet, because the Quality and Safety Committee have only sat relatively recently, and the next strategic expert by experience has not yet sat. However, our patient involvement team have that planned in with the group, and we will be able to bring that feedback back through the committee and then board.
Thank you. Paul.
I just looking at the overdue incidents, quite an improvement. But when I look at the data again, I said, if I take the 800 in Wiltshire out of it, actually there is no improvement in the rest. I know just thinking that what happened may just be too detailed, but what I'm going after really is how will this not creep up again in Wiltshire, especially?
So in Wiltshire particularly, the open overdue incidents related to two particular teams who had a very significant number. So one of those was Beechley Dean Ward, and one of those was Poppy Ward. And when we investigated those procedures, we found that they had single points of failure in each of those areas. So the incidents were only being reviewed by one person, and when that person was absent, then the incidents were not being reviewed. So we've opened up the number of different people within the team now who review those incidents together, and they use a systematic process to do that rather than relying on one person. Thank you, Paul.
Last question.
Can I just add a bit to the answer? There was just one other bit you mentioned about 800 going down in Wiltshire. This is a monthly paper, and we had seen a big reduction in Bristol before. So it isn't that they haven't reduced the number, that Bristol got their action plan sorted sooner, so Wiltshire came along after. So, sorry.
That's okay. I'm going to draw this to a close again, mindful of the length of this agenda today. We were asked to take short from the report. The report has been to the QSC before it came here. And note that there are detailed improvement plans and key work streams to progress that are progressed through CEOG. Is the board happy to take assurance, the part of assurance with minor improvements required for this paper? Yeah? Yes. Okay, thank you. Can we move on then to the month 12 integrated quality performance report, please?
Thank you, Chair. So I'll start and then I'll hand over to Matthew to talk about performance. So in relation to the quality aspects of the paper, I would draw your attention to an issue that has arisen within our secure service line in respect to the historical clinical risk management risk assessments, or what we call HCR20s. These are a specific risk assessment that are used within mostly in secure services, and they relate to the management and prediction of violence and aggression in those services. So it was flagged by the service that their performance had significantly dropped. And this was because they had been reliant on their psychologist workforce completing the HCR20 risk assessments, rather than having a multidisciplinary approach to those. Having picked up on that, they have done work immediately to provide mitigation, and that includes them identifying those people who are at highest risk, who are about to be discharged, or who are subject to particular safeguarding processes, such as the multi-agency public protection processes. And those risk assessments have been updated or completed in order to make sure that nobody is being discharged from the service without that risk assessment having been completed. At the same time, they have then been working their way through those other risk assessments that need to be updated or completed, and their performance has improved now to 37%, and they have a trajectory improvement plan in place to meet the targets within, I think, the end of Q1. They have also been training the other staff in order to create a more multidisciplinary approach to the undertaking of these HCR20 assessments moving forward, and we will continue to monitor this particular issue and the progress that's made through the Safety, Effectiveness and Experience Oversight Group and report through to Quality and Safety Committee. Also wanted to flag to the board the reducing restrictive intervention training, and again we have been working with our secure service line to improve their performance. They're currently now achieving a 73% compliance, which has been an improvement on where they have previously been. they've been exploring that further and have identified that some of that lack of compliance relates to exemptions. So those people who either temporarily or due to ongoing health reasons are unable to complete the reducing restrictive intervention training. So they are working with their HR colleagues and with occupational health to review those exemptions and again to make sure that we achieve the compliance and that we exclude those who are exempt from that. What mitigation we have in place to manage that risk at the moment is that there is a fully trained response team on duty 24/7 within that service who are able to respond to any incidents that occur whilst we get that compliance further improved. And then the final point that I wanted to make was in relation to patients with an annual review of care, or what we call Care Programme Approach, CPA, and wanted to flag the issue with the performance related to BNSSG, which the board might note has significantly decreased over the last few months. That decrease is related to a good thing, not a bad thing. So it's related to the implementation of our new approach to replace CPA, which is your team, your conversation, your plan, which is a fully co-produced new approach. And that's affecting the CPA metric as we transition people from one to the other. But what we are doing is reviewing then the performance in relation to the CPA metric and how often people have a review with CPA versus then the numbers of people who've had a new review with your team, your conversation, your plan, and can confirm that they are balancing so that we are ensuring that everyone has had a review. As we move forward with the implementation of your team, your conversation, your plan, this performance reporting will move over whole scale to the new metrics that will give us a better oversight of whether or not people have had an appropriate review and been involved in that review as well. So those were the points that I was going to raise in respect to quality. So we can either pause now, Chair, and take questions on quality, or move over to Matthew and Paul.
Can I move over to Matthew and then we'll take all the questions at the end?
Thank you, Sarah, and thank you, Chair. I'm just going to pick out a few bits from the performance section that relates to some of our key areas of concern, activity and risk. First is the work around our inpatient services and ensuring that we provide adequate access to hospital beds in a timely way. So minimising the numbers of patients needing to be placed outside of AWP and potentially a long way from home. We've continued to focus on that. It obviously does cross-reference with our savings program as well, so it's both quality and financial priority for us. And there has been some improvements over the last months following some increases in the number of people placed out of area, changes we've made to bed configurations and the implementation of revised bed management processes that we're labelling, developing concept of a transfer of care. We've seen some significant improvements, so that remains focused, and the longer term positive impact on that we anticipate being achieved through changes in our crisis treatment response. And the second area I just wanted to comment on was around referral to assessment. This is the main access into our main adult services, recognising we have seen a deterioration to that over the last months, noting that there are various procedural issues that we need to ensure compliance with. So we're having a refocus on that in the immediate term, and also noting the changes that we're making to all of our access services in line with the community transformation, which the board had more detail on in the seminar last week. Third area I just wanted to comment on quickly is around talking therapies. So this is the main Swindon and Wiltshire service that previously was referred to as the Integrating Access to Psychological Therapies, IAPT service. It's now Talking Therapies. And we've had concerns along with the Integrated Care Board around performance of that service. So we've put particular plans in place. We've agreed with the ICB. We've made significant improvements. The main outstanding challenge we've got is the numbers of patients, so the overall levels of activity within the service. We've seen improvements in waiting times, minimising the amount of time people are waiting, and clinical outcomes. We do need to see more people, so we're continuing to focus on that. We've got a range of solutions around digital changes in the work, how we use and work with our workforce. that we anticipate improve that, and thanks to the communications team who've provided really comprehensive solution to help people realise and access the talk therapy service. The final one to comment on is around CAMHS access. So we have like talk therapies and a number of people that we're expected to provide a service to each year, and we've been significantly below that for a period of time. We've been doing a piece of work again with, this is in the Bristol, North Southern and South Gloucestershire integrated care system. We've got some work that we need to do. We've worked with the integrated care board to come up with a plan, and there is quite a stretch target associated with this, because some of the activity that was being counted as part of the overall numbers of young people accessing services, so it relates to neurodevelopmental assessments, isn't actually now able to be included. So we need to make a further stepped increase. There is a development plan around that, an improvement plan, which was reviewed by the executive team yesterday, and more work underway to improve that, similar to some of the things that we've done in talking therapies that have started to see some success. That's all I wanted to say today. Thank you.
Thank you, Matthew. Any questions? Mindful again that these papers have gone through the respective subcommittees of the board. Questions for either Matthew or Sarah, please. Paul Miller, please.
Just a quick one. Given the importance of inpatient occupancy, because we need to reduce our out of area beds, etc., I noticed a comment under BSW inpatient around delays relating to Ministry of Justice restrictions. What are these restrictions that reduce our throughput in terms of Ministry of Justice, and are there any things that we can do about this?
Yeah, that's quite a potentially a complicated answer, what sounds like a simple question. So people convicted of an offence and having a disposal under the Mental Health Act can have Home Office restrictions, or Ministry of Justice restrictions applied. So that would be usually, in this case, under Section 41 of the Mental Health Act. That means that it is the Justice Secretary's decision as to when and where people move in and out of hospital, and that goes through a process which is different to the local processes that we would have when someone's in hospital, either informally or detained under the Mental Health Act, where the local team would be making decisions. So there's a different perspective on risk management, because the Justice Department, Ministry of Justice work to a different type of protocol. It's not purely clinical in the way that our decision making is, and so it means that sometimes decisions that need that sign off take longer than they would if they were a purely local clinical decision. Does that make sense, Paul?
It makes total sense, and again it goes back to not a discussion now but just a thought. It goes back to my earlier question about that relationship then the Ministry of Justice and Secure Services, and where one starts and one stops.
Yeah, shall I comment on that as well? No. Very quickly. Yes, one does need to have a good relationship with those departments. They are obviously based in London. This is civil servants undertaking this work, not clinicians. Those civil servants move quite a lot, so it's not straightforward to have a relationship in the way that you might say with social care in Bristol City Council, for instance. In this case in point, this isn't actually Secure Services, this is the BSW inpatient services. Yep. So at any one time, there will be not many, but a handful of people who do have these types of restrictions in our acute and PICU wards, as well as obviously a much greater proportion in our Secure Services.
Thank you, Matthew.
Sorry, it was a long answer.
No, that's fine. Thank you. I am going to close down any other questions unless anybody's got a burning question. Oh, nothing more on, is it? Okay, I'm going to close I'm going to thank both Sarah and Matthew. The recommendation is that the board take assurance against the information that was in the integrated performance paper, partial assurance with improvements required because there is additional work to do. Are we in agreement with that assurance rating and the assurance that we received? Yes?
Yes.
Thank you. Now, I am going to defer the insertive outreach paper until after the patient's story, because we've got a patient that is coming with their story. We are running late and we were due to have the patient's story at 25 past. So I'm going to keep that to 1:30 if we can come back, have a quick break, come back for 1:30, we'll have the patient's story and then the insertive outreach paper after that. I will keep saying this all the way through the meeting. The compact agenda and the time that we've got, so I will remind you. It's time for us to have our patient story, and I'd like to welcome Edna and Anna to the board. Edna, thank you for coming along to share with us your experience and services. Feel free to share and also try and feel comfortable. I know it's always daunting when you're talking to lots of people, but we really are interested in what you've got to say, and thank you. So I'm going to hand the floor over to you. We'll listen to you, then spot question. We may have some questions after, if that's all right.
Yeah, well, I'll try to answer questions. I won't make promises, but I promise I'll try. Yes, I'm Edna. I've been involved one way or another with AWP for about 15 years, I think, something like that. I'm currently involved in delivering the carer awareness training in South Gloss. Recently, I was involved in helping to plan and deliver the Your Team, Your Conversation training. Did all the South Gloss ones, I think about half the North Somerset ones, which was a bit of a trek, and just over half of the Bristol ones. So I'm used to talking. I don't mind talking to a lot of people, but I used to be able to do it without notes. I don't have that confidence anymore. 20 years ago, I would quite happily come here and talk to you 20 minutes without any notes, but not now. So it's got to be down on pieces of paper. I also get involved sometimes in interview panels and other things that come up in South Gloss. They call me an involvee and I hate the word. So I prefer involvement volunteer. But anyway, it's what they call me, and I get involved in a lot of things. In fact, just before Christmas, I had to realise that I really was doing too much, because I do other things outside AWP as well. And at the time, both of the trainings were happening at the same time. So I had to be strict with myself more than anybody else, and say I can only do one a week. No, but because I am getting a little bit long in the tooth now. And, one of the results of that, as well as having less energy than I used to have, is this business of not having the confidence to work without notes anymore. However, what you want to know, I hope, is why I do what I do and how I got involved. It all goes back to my husband, really. He died in 2011. And I feel that what I do now is part, and probably a large part, of his legacy. John was the most mild-mannered of men, quiet, gentle, unassuming, and totally unselfish. He didn't smoke, didn't drink much, kept himself fit, was never an ounce overweight, unlike his wife, enjoyed cycling and walking, and then he was struck by Lewy body dementia and the Parkinsonism that went along with it. And I began to lose the man I'd married 40 odd years before. Learning that my husband had dementia in his early 60s was a terrible blow. And I couldn't really believe it. And I didn't want to believe it. This couldn't be happening to us, this is the sort of thing that happens to other people, not to us. I think a lot of carers feel like that. After a bit, I had to admit to myself that it was true. I didn't want anyone else to know. I felt ashamed to tell people that my husband had dementia. Why should I feel ashamed about my husband's illness? Wasn't my fault, wasn't his fault either. But it's how I felt. And again, I think that other carers often feel like that too. I shall never be an expert on dementia, but I knew nothing about it then, and I didn't want to know. I didn't want to look at the wodge of information we'd been given with the diagnosis. I didn't want to think about something that was out of my control. And I most certainly didn't want to be labelled a carer. After a bit, though, I began to realise that actually it was easier when people knew what was going on. People who were close to us realised there was something wrong anyway, and some of them actually had a pretty good idea of what it was. So I started to talk to friends and neighbours, and they were very understanding and supportive, although none of them had experienced what I was going through themselves. John became more and more difficult. His personality seemed to change completely. He got very agitated sometimes, became self-centred, and he had been totally unselfish before. Slept half the day, couldn't sleep at night, which meant I was awake half the night too. He started hallucinating, had trouble processing what his eyes were seeing. And one of the hard things for him was that he had to give up cycling because of his balance. But he was still able to walk 3 or 4 miles without difficulty, and was able to forget some of his problems and chat happily, if not always coherently, when walking in the country. He'd sometimes get stuck on stiles though. You know, he'd get up on the top and then he didn't want to get down the other side. So I had to try to be patient and find ways of persuading him to get down without upsetting him or making him angry. Sometimes he'd get frightened of steps or getting in the car for reasons which I couldn't understand. There was one occasion when I actually got hold of him and bundled him into the car, and I have felt guilty about that ever since. Patience has never been one of my strong points, and I think I often made things worse rather than better. There was so much that I couldn't understand or be prepared for. I seemed to be constantly reacting to unexpected situations. And even if I worked out a plan for how to deal with something, if it happened a second time, he'd probably behave totally differently the next time, and my plan went out the window. On one occasion, he got stuck 3 steps down from the top of the stairs. Frightened to go up, frightened to go down, just clinging to the banister. I was upstairs at the time. I managed to squeeze past him because I thought perhaps it was safer for him if I was below him. But he got agitated. I got agitated. He got even more agitated. I just didn't know what to do. Fortunately, my son walked in after about 20 minutes. Go away, Mum. Let me deal with it. You're making things worse. Absolutely right. I was making things worse. I was very grateful to go away and let him deal with it. Took a while. I don't know what he said or what he did, but somehow or other, he got him down the stairs. I don't know what would have happened if he hadn't walked in just then, to be honest. He lived in London, just happened to be in Bristol to work that day. After I calmed down and had time to think about things, I decided I'd be prepared if it happened again. I'd always make sure that I was below John on the stairs. That bit I managed. Then I would sit down on the stairs, get him to sit down behind me, and we'd both go down on our bottom. Problem solved. It happened again. And try as I might, I couldn't get him to sit down. Best laid plans and all that. I found all this extremely difficult. I don't think I'm a born carer. Some people are, but I don't think I am. But looking back, it's probably given me a lot more understanding of what other people are going through now. And I probably wouldn't be able to do the things I do, certainly the things I do with people with dementia and their carers now, if I hadn't gone through all that. I think I'm a reasonably capable person, and hard as it was, I thought I ought to be able to cope with this situation. But it became clear that I couldn't, not on my own. Although as the strain and the sleepless nights began to take their toll, friends were more aware of it at times than I was. And they started telling me that there was help out there and I should go and ask for it. For me, that was a big hurdle to get over. But in the end, I realised that I really had to swallow my pride and go and ask for help. I guess that was quite a breakthrough, really. And when I did ask, people did help. Friends formed a rota to take John out for a couple of hours once a week, which gave me that little bit of time to myself. We got support from the Alzheimer's Society. And after a very fraught telephone conversation with a consultant, when I got very angry and shouted and cried, that may not have saved my life, but it certainly saved my sanity. In particular, the support we got from Cheryl, our CPN, was absolutely invaluable. She got in touch with social services one day when she stood in my lounge and realised that I was in such a state that she didn't know where I was going, and arranged respite, a week's respite, just like that, which was absolutely amazing. It was also arranged that John would spend one day a week at the Limes Day Centre for people under 70. Sadly, that no longer exists. I was talking to the person who used to run it at the funerals, it happens just a couple of weeks ago. And it's just so sad, I think, that it doesn't exist anymore. It was a lovely place. John enjoyed going there. And I like to take him in rather than use the transport. It's really good to meet them. And honestly, you could feel the love there. I wish other people could have that sort of facility, but it doesn't happen at the moment. Maybe it will. John also did the life story course and various other courses and exercise groups run by AWP, all of which gave me a bit of a break. And I'm not sure that any of it would have happened without Cheryl. She visited us regularly and was always at the end of a telephone if I needed her. When John had a fall and spent time in hospital and then in a nursing home, she didn't desert us. She was still there for us. I have an abiding memory of Cheryl sitting at the end of John's bed in Southmead, massaging his feet. He absolutely loved it. And I had to try and do it afterwards, but I never did it as well as Cheryl. Caring 24/7 for a person with dementia is probably the hardest job in the world. Definitely one of the hardest anyway. But I guess it's probably just as hard, though different, for people who care for loved ones with other conditions. Anyway, it was certainly the hardest job I've ever tackled. And the only one at which I frequently felt I was failing. To some extent, what I do now may be an attempt to make up for that by helping other people to cope better. I'm not sure about that. It was extremely wearing. As I said before, I often got very little sleep. And believe me, 4 hours a night for weeks on end leaves you less alert than you'd like to be when you know that you need to be constantly vigilant. Leaves you irritable when you know you should be patient and gentle. And then you feel guilty. I guess I sometimes felt a bit resentful too. My own life seemed to be put on hold. Being a carer seemed to absorb me completely. I felt that that's all I was. The real me had got lost in there somewhere. And after John died, it took me a while to find myself again. I'm not sure that I'm exactly the same me now as I was then, but this is the one you get now anyway, like it or not. So how did all this get me to where I am now and what I'm doing now? Well, one thing led to another, really. And that's what still seems to keep happening. A few months after John died, I decided I would like to volunteer at the activity group run by the Alzheimer's Society that we used to go to together. Did that for a little while. And then the Alzheimer's Society asked me if I would be interviewed about my role as a carer on Radio Bristol. I think it was probably during Carers Week, but it's a long time ago. I can't exactly remember all the detail. But our friend Cheryl, the CPN that we'd had while John was ill, heard the programme and mentioned it to the volunteer coordinator, if that was her title at the time. You know better than I do about that. But she thought that I was the person she was looking for to speak at a series of events across South Gloucestershire to raise awareness of dementia. I think it was actually organised by South Gloucestershire Council, but AWP were asked to find somebody to talk. I did that, and I was now well and truly caught up in things with AWP. And one thing kept leading to another. That's how I first got to know Anna, though neither of us can quite remember how many years ago it was. It's a long time, yes. Anna. Then I got involved with the current volunteer coordinator in South Gloss, Nick Birchall. Actually, I was involved on her interview panel, so it's partly my own fault. And that, among other things, has led me to what is really my first priority these days. One of the things which I think might have helped me when I was caring for John would have been the opportunity to meet and share with other carers. But there were carers groups offered, but I couldn't go to them because I couldn't leave John at home by himself. So when Nick said to me that AWP were planning to run a 6-week carers wellbeing course, whereby carers would be in one room with a member of staff and volunteers and would work through the 5 ways to wellbeing, and that the people they're caring for would be in the next room, looked after by OTs and you know, activities done for them. And would I like to be involved? I jumped at it. To cut a long story short, at the end of that course, the carers were all saying how much they valued it and wished it could go on longer. AWP wasn't in a position to go further with it though. Don't use the money for one thing. So with their support, a lot of support from AWP, we decided to set up a group for people with dementia and their carers, run entirely by volunteers in Winterbourne. We ran once a month to begin with. Several more of the wellbeing courses were run by AWP, and they fed into our group. The result of that was that we had to start running twice a month, 2 separate groups, because we only had 4 volunteers, and if it got too big, you know, we just couldn't cope with it. That was 7 years ago. Disrupted, of course, by COVID, but throughout all that, we divided the list of our members between us, and we kept in touch with all of them throughout that. And as soon as we were allowed to, we started meeting again outdoors. Initially in Page Park in Staple Hill, where there's one of these concrete table tennis tables. And a lot of our people absolutely love playing table tennis. It was a real revelation to me when we were at that activity group that run by the Alzheimer's Society while John was ill, just how people with dementia who said they hadn't played table tennis for 40 years would actually play and get better at it. And what else, you know, what else can people with dementia actually get better at? Absolutely wonderful for their self-esteem. So as soon as we could go in the park and play at the table tennis table, we started doing that. And then we started meeting actually in the garden behind where we normally meet, which is at Winterbourne Community Centre. We call ourselves Wellbeing Friends. When COVID was sort of over and we were able to get back to something like normal, although normal's not a good word to use for our Wellbeing Friends. I don't think we're normal at all, but we said, okay, we would start meeting twice a month again, but they could come to both to start with, because we really didn't know how many people would be coming back. We didn't actually lose anybody to COVID, but we lost a few people during COVID. So we didn't know what the numbers were going to be like. And through COVID, the last bit of that time when we were restricted to meeting outdoors, we met every week. Nothing else was going on. All the Alzheimer's groups had stopped. All the groups run by anybody else had stopped. So we met every week with groups getting gradually bigger and bigger outdoors. as I say, when we started to go back indoors, we said we'd meet twice a month again, and they could come to both to start with. But if the numbers got too big, we would have to split. We now have 10 volunteers, and the group has gelled so well together that there's no way we can split it. Absolutely no way we can split it. Last week, we had 32 members with 6 volunteers, and there were 6 or 7 other people who might have been there. Some can only come on the Wednesday session, some can only come on the Thursday session, and sometimes people have hospital appointments and all sorts of things, so they can't always be there. But we knew there were, there was a potential for another 6 or 7 people to be there. But that's always going to happen, really, and I think that's the most we've ever had at a session so far. So 2 afternoons a month, and just for a couple of hours, we have a lot of fun together. Nothing normal about it. And it gives carers a valuable break and a chance to share with others who understand what they're going through. They love it, and I believe they draw strength from it. It can get a bit mad at times and very noisy. When John had dementia, I was convinced that people with dementia couldn't stand noise. That Alzheimer's group used to meet in a sports hall. We had half the sports hall. And sometimes there was a group of young people, I can't remember quite what their disabilities were, but they were in the other part of the hall, and they made a lot of noise. And our people, you could see them kind of shrinking away, and they just did not like it. Since running Wellbeing Friends, I've come to the conclusion that they don't like noise if someone else is making it, but as long as they're engaged in it and making the noise themselves, it doesn't matter how much noise you make. It's very chaotic. We have, at the end of the session, we have 4 games going on around the room. Curling, boccia, and a couple of games involving beanbags. All at once, they get very competitive, and some of them get very noisy. It's amazing. It's chaos, but it's really good fun. And I think the more activities there are for people of that kind, the more it helps carers to cope. I'm sure that's right. For me, this is one of the most satisfying and fulfilling things I've ever done. Yeah, I'm grateful for AWP's continuing support, and I hope that we'll eventually start to run the Carers Wellbeing courses again. I'm sure people want to, but you know better than I do what the problems are in starting that up again. When they do, I'm sure we'll have room for people to join us again, because obviously with the sort of people that we're working with, people kind of drop off at the other end, while others can come in at the beginning. We shan't separate. We shall certainly continue to run twice a month where everybody can come. So if you want me to do anything on a day that clashes with Wellbeing Friends, I shall have no difficulty in saying a resounding no. At other times, I hope I shall be able to say yes for a while longer. Thank you. And I wasn't sure whether to let you on or not.
You were right not to. We haven't got a lot of time, but I'd like to open up for questions because that was a fascinating and a really insightful personal story that I think has certainly impacted me just listening to you. So I'm going to open it up for a few questions. Again, I've been saying this is my mantra all through this meeting. Not too many please because of where we are. But please take the opportunity to have a conversation with Edna because it's been fascinating. Thank you. So questions, please. Alice.
Thank you. Yeah, thank you for coming, for sharing, and for doing all of the work you do. And for me, it's really an amazing piece of learning about actually like carers. I think they are a silent group sometimes. And it's so much that you endure. And actually, it's like, as you said, about you feel you've got lost a little bit. And one of our roles is to help you not get lost by making sure that we can give you the support. It doesn't have to be just us, it can be lots of people, but to help you and guide you in that. So I just wanted to say thank you for doing that, for speaking out, on behalf of all the carers? Am I constantly making everyone stand up and go, okay, yes, there's somebody else behind the patient that we're dealing with that actually we really also need to give attention to.
Thank you. Obviously, that's the sort of thing we keep saying in the carers awareness training. I was only in my mid-60s when I was going through with Only. A lot of the people that we have at Wellbeing Friends are in their late 80s or 90s, made me feel quite young. Not anymore. But, you know, and how they cope sometimes, I really don't know.
Edward, can I just ask you, you talked about shame a lot. And is there anything you would like from us as an organisation to help carers to lessen that sense of shame?
It's a difficult one, isn't it? I mean, I'm talking quite a long time ago now, and at the time, dementia wasn't talked about very much anyway. You know, John was diagnosed in 2009, having been previously diagnosed with Parkinsonism. Well, they said Parkinson's properly then, but it obviously was to do with the Lewy body. So it's a while ago. And I can remember people saying, why don't people talk about dementia? We talk about cancer. We're getting rid of the stigma with cancer. Why can't, that was 15 years ago. Surely it has improved, hasn't it? But it's just one of those things, because it's something, you know, that affects the brain. It seems to be more difficult to accept it. And again, I think, you know, any groups like ours, where you can go and meet other people that are going through the same thing, are going to help. Sometimes difficult for people to come to start with, though, and that may be part of that. And recently we've got more younger people in their early 60s, and I think it's taken a while for them to feel they could come to something like this, you know, and but they are speaking out an awful lot more. The carers are speaking out an awful lot more than I can remember doing at the time that I was going through it. You know, yes, I got very angry with that consultant on the phone and shouted at her, and I could go and stand in a meeting that I'd been invited to and talk about it. But somehow, you know, you were already in the system then. So I hope that it's society in general that will actually change that attitude. But I'm not sure what we can do in the meanwhile to ensure that happens.
Okay, thank you. Any other comments? Anybody want to say anything else before we take the opportunity to thank Edna?
I suppose I just wanted you to know that your story really resonated, and I think it will resonate with the people around this room. And that means something, because it means we'll hold it and we'll be passionate about supporting carers in the future. And I just wanted to say that out there because it was powerful.
Thank you.
Thank you.
Thank you very much.
I would thank everyone, all of us. Because when I look at us, I say we all end up a carer at one stage or the other. And we better listen to you. That's all I would say. Thank you.
And that did just make me think then, you know, obviously there are quite a number of staff who are carers too. And I know there's an online thing, isn't there, for them to go to and so on. But, you know, I think, and obviously they are people that you can support in a way that I obviously can't.
Well, I think again express our thanks and our gratitude that you've taken your time to come and share your story with us. And I certainly think, as Alison and Paul have both highlighted, what you said will stay with us because it is personal. And it's something that we probably will experience at some point. So thank you very much for your time, and thank you for the support that you give to AWP in relation to your voluntary work. We really appreciate that.
Well, AWP, like I say, saved my sanity, if not my life. So it doesn't hurt me to give a bit.
Not leaving a rubbish bin on.
Thank you.
Thank you.
I'll take this back then to, the agenda item that was we were due to have before the break. That we do independent mental health on the side of the circuit outreach document, please. Yeah, that's there, yes, thank you.
Thank you, Chair. So this report comes to board following the publication of the mental health independent mental health homicide review into the care of Valdo Alkane, Nottingham Healthcare Foundation Trust. So there have been a number of reviews related to this case. So the Trust first responded to the two CQC reports related to their special review earlier, back in 2024. And this report then provides us with a review of that work and also provides us with an analysis of where the recommendations from the mental health homicide review align with our existing work plan, where we had gaps and where we need to strengthen our recommendations. So I will just highlight a couple of things from the report. So first of all, to respond to this, we formed a working group, and that's a multidisciplinary working group, which involves our transformation team and also our clinical teams and operational teams as well. There were a number of kind of themes of recommendations related to care delivery, related to incident reviews, family engagement, and other areas. And you can see from the paper, so I won't go through in detail, how we are progressing with our work in relation to the AWP action plan related to those areas. We've also undertaken some analysis of our caseloads within our services as one of the work streams that we've been undertaking. So we've looked at where service users who might have previously been cared for under an assertive outreach approach when we had those teams within our services, where are they within our current services, as we no longer have separate assertive outreach teams in place. And we analysed some of the discharge processes for those people who had serious mental illness with a diagnosis of a psychotic presentation, and looked at those discharge processes. And what we found when we've looked at that in the NSSG area is that those discharges have met the policy requirements that we currently have in place. So we didn't find any specific issues with that. However, we did find some learning for us to take forward with respect to that, which, excuse me, and apologies, my papers are moving around, related to a clearer plan in place to anticipate any changes in presentation and then the re-access of the service once somebody had been discharged. So we've mitigated that risk that we found through that work by rapidly implementing a new discharge checklist for staff to go through to make sure that those re-access plans are in place before somebody is discharged. And then we are continuing to work on updating our non-engagement policy to reflect those processes and prioritising further audit of that work to understand whether that's had an impact on the quality of those discharges. The other piece of work that we're doing is that audit process has shown us that it's actually been quite difficult for us to identify that cohort of people who potentially might non-engage, who would fall into the serious mental illness category with a diagnosis of a psychotic illness. And so we need to do some work using our business intelligence team, but also our clinical teams in order to identify that cohort moving forward within our recovery and community mental health services, in order that we can then analyse are there any unmet needs within those service user groups that we need to adjust our practice in order to be able to provide more support for that cohort. So those were the two key things that have come out of this piece of analysis work that we're taking forward. Some of the work in terms of clinical models that we will be taking forward to address that second risk that I identified are already included within our community transformation work, and also then with the work that we'll be progressing through this year through the pathways work, particularly through the pathways for people with psychosis. So we will be further strengthening our actions as a result of that. So this paper really is for the board to consider the progress that we've made, the risks that we've identified, and subsequent mitigations and plans.
Thank you, Sarah. Any questions? Oh, would you like?
One very quick one. I like the paper. It identifies a set of actions in the comments box and also a set of mitigations for the two risks. What I didn't see was any date by when these mitigations would be concluded, or identify the who would be doing it. I appreciate it might be embedded in other things, Sarah, but for me to get assurance, I get assurance you know what to do. I don't get assurance by when we're going to do it or who's going to do it from this paper, if that makes sense.
Thank you, Paul. I think that's a fair point. There is a substantial action plan that sits behind this paper, which has those identified people and those dates for delivery. That isn't included within the paper, as there are. It's quite large for a start. And so the idea of this paper was simply to highlight to the board where there were, what work we'd done, where there were gaps, and how we were taking.
Thank you.
Might be a test.
Just a follow on from that and a query. Is that plan part of QSC committee review? And so therefore that's where the assurance is. And could we include that assurance process in the papers coming forward in the future? Question.
Yeah.
Just to answer Paul's question, because obviously we would normally do that level of detail in the board.
So my response to that would be that the committee will get an escalation report from that work that will highlight any issues with carrying that work forward, but the action plan will be overseen by the transformation programme and the operational delivery, but escalations of any issues arising from that will absolutely come to future reports, the Quality and Safety Committee. Thank you.
That's fine, I was just going to do. Yeah, okay. Thank you. Any other questions for Sarah?
I just want to say that I really appreciate the work that has been done by the business intelligence team, which is trying to identify the clusters and possibly predict who may be a non-engagement person. And it just resonates with me because of what we used to do. I used to work, we predict students from their A-level results, whether they will drop out after 1 year in the university. So, and I'm just thinking of how we can use more of this intelligence to actually predict those who eventually do not engage. And if we back it to maybe 10, 15 years, possibly we may begin to understand it. And I just want to show appreciation for the work of the. It has started, but we need to just work a little bit more.
Thank you, Paul. I think we're working towards those types of aspirations, but that type of analysis is probably a ways off for us in terms of our capability to do that predictive analysis. And the other thing that I would raise in that is, of course, the relationship with the clinician is key in terms of that engagement as well. And that's much more difficult to predict. So we need a combination of a data analysis and BI approach and a clinical approach coming together to give us exactly what you described. Thank you.
Sarah, I wonder if you could say a little bit about when all of the trusts have concluded their assessments, what you think some of the national learnings will be and what will some of the national guidance be? Because I can't imagine that the things that we're finding will just be particular to us. We will see that replicated. So do you have any sense of what national guidance might come or what the national next steps would be?
So I think that I don't think that there would be anything specific. I think that the learning from the CQC and from the mental health homicide review, that NHS England will incorporate that into future approaches. And we're already starting to see some of that, where new guidance is being issued around personalised care frameworks, for instance, the direct consultation at the moment that are incorporating some of the learning from these things. But I wouldn't anticipate that we would get assertive outreach team guidance, if you like, and we're not anticipating that there will be a particular funding stream that will come alongside that. I think when we were in 2024, that was something that was being discussed, but that now I think is unlikely to happen.
Thank you. So one action I think has come out of this conversation in relation to dates in your action plan in terms of when those actions will be concluded, although we hear that that will be monitored in another arena. I think we've also heard as well that monitoring of the progress against the homicide review will take place at QSC, or subsequent papers will come back to us.
Yes.
Yeah, back to QSC. Okay. The paper recommends that we consider the progress in the some mitigations to note the report. Do we note the report as into the board? Yes. Okay. All right then. Can we move on to the People, Culture and Leadership Committee Chair's report, and Julian is going to just synthesise what we had on Monday, very, very briefly. I am going to say that we are running late, and clearly because we've got part two and we've got another meeting before part two, I'll just ask you to be mindful and help me as a unitary body, the unitary board, to ensure that we can actually move forward and lead with the agenda. Julian, please.
So, on Jan's behalf, the People Committee was on Monday, so no chance for a report. We, as a matter of note, we had a cross-reference from, I think, Quality and Standards about how we're getting on with installing a just and restorative culture into secure services. So we had an item which allowed us to discuss that, which was accepted, and we had a good discussion about the topics in the People Committee this week. We had a lot about staff experience matters. So we had a closure report for the People Promise project, explaining in great detail how that had gone for a year and the impact it had, with lots of staff experience initiatives that had been embedded into the organisation. That received good assurance. We had a paper on health, wellbeing and retention. And one of the items that we flagged was about the staff trauma service, where people have terrible incidents happen and the number of people and the increasing number of people that use that service. We had our item on workforce planning. We acknowledged that we're currently at nearly 92% of our workforce is filled with substantive staff, which is the best it's been for about 3 million years. And we're no longer the worst performing trust in the country, so that's nice as well. EDI, we had a paper that's reflected all of the variety of work that had happened over the last year and it was going on. We had learning and development also, particularly there around the volume of development that happens and how we're trying to manage that to a reasonable level despite increasing demands for training. And then finally, there were two items about the medical workforce. There was it was ROAG, Responsible Officer
Advisory Group.
There you go, thank you. Which is about how we are supporting our doctors and what kind of experience they're having, and also the Guardian of Safe Working report was reviewed and accepted in the meeting too.
Yeah, thank you, Julian. Paul, so if you wanted to add?
three really quick points. We'll pick it up in the next paper, but we spent a little bit of time talking about one of the statistics about disabled staff, the highest percentage of voluntary resignations in 9 years amongst disabled staff. So there's a takeaway to have a little bit of a look at that. We asked a question about, given our success in terms of lowering turnover in the trust, whether we should set a new ambition with a slightly more ambitious target, maybe 10%, etc. So we are going to take that away and have a little look at that. And then maybe one for this afternoon. We had an interesting conversation about over-establishment, particularly in BNSSG, where I think it was running at 109%, and we got some good insight from Sarah in particular around why that might be, but that's probably a conversation for this afternoon, I'd suggest.
Yeah, okay. And just finding good news in the sense of appraisals. That I think it's 90% of staff across the organisation have been appraised to date.
91 by today.
91. So we're doing really well with that. Okay, thank you, Julian and Paul, for actually just stepping in for me there. If there are no questions, can we then move on to the public sector quality duty?
So I'll give this briefly. As you can see in the paper, this comes every year. So those that have been here a while, you've seen this a few times. It's a report we're required to produce. It's been to the committee. It's also been to the executive board as well. It's been all over the place. And it gives an indicator of the kind of breakdown of our organisation in a great many respects, and of our service users, and a number of other aspects as well. So it's an information kind of report that we are legally required to produce and give access to for the public. It's actually online. I guess some absolute mega headlines, which I hope you won't be surprised. Our workforce has grown. It continues to grow. It grew 7% in the last year. And just to the side, that doesn't mean that corporate functions, we struggle sometimes to keep up with the increases in our workforce because we don't grow. So that's something that's worthy of note. We're up to, as of today, interesting, an update, 21% of our workforce is now from BME background, which is highest it's been for a very long time. And of course, we're still making efforts, lots of efforts to try and get the balance of what roles they're in, what seniority of those roles are. But to have a groundswell is clearly positive. Leavers, I always find this report is good for highlighting our successes on just having less leavers each year. The trend is downwards, including those that leave in the first year, despite the slight blip as far as disability issues are concerned. And that's purposeful. We chose that we wanted to focus over the long period on reducing leavers, retaining people better, particularly in that first year. And you'll also see as a final point, the bank. We rely on our bank enormously to cover our gaps, and the bank has increased by 18% in the last year. And there's breakdowns of how it's made up the bank, but we've got to keep that bank operating healthy and of a reasonable size. So there's some highlights from my perspective, but the report has many, many stats that you can look at in the bath with a bottle of wine sometime.
Thank you, Julie. Question?
So mine's a question that linked into the paper that we had earlier to speak up in terms of the number of staff we've got, like over 5,000, got 124 freedom to speak up champions. We said that those coming from BME groups is 21%, would you say?
Well, it's 20%, 17%.
It's only 17 in that group that are freedom to speak up. Yeah. So just thinking about those percentages, maybe it's more of a comment about looking at those, and I'd be interested in the analysis of how to speak up champions aligns with that data, which I'm sure has been done in the background, but it would just be interesting to see a bit more about that in the future.
Okay, thank you.
Not a question to ask now, but one to reflect on and maybe discuss at the People Committee. In paragraph 6 under substantive workforce, it says our global majority staff representatives have reduced by 4%. Then a couple of lines, then the line below that says that is despite our band 3s from global majority increasing very significantly. So that gives me the understanding that if we hadn't had that significant increase in band 3s, the global majority reduction would be even bigger. and therefore it seems to maybe hide the fact that we're reducing in band 4s, 5s, 6s and 7s. Is my kind of crude mathematics right here? So not for discussion now, but we've got two things: total numbers going down and band 3s going up.
If I could just, maybe if you could send me an email with that written down, Paul, because that was a little hard to follow, but then I can follow up with you perhaps afterwards. That'd be useful.
Yeah, no problem at all.
Thanks very much.
Sorry, can I can't let them on go a little bit, just to clarify, I think, Julian, you said it in the report that the overall figure has increased. It's not decreased.
The overall number of BME staff has increased by 4%.
So the line that Paul referred to.
I see the minus. Yeah.
Yeah, it's a dash, not a minus, I think. It's probably with the presentation.
That would be,
it's a
thank you for that. That's very helpful. Thank you.
Just to follow that up, that increase is particularly there because of the international recruitment.
That's part of it. I mean, we've taken on about 120 or so. So yes, that's certainly helped. Yes. But we've also taken a lot of applicants for our healthcare support workers, particularly.
Thank you. When do we deal with where do we deal with pay differentials?
With
pay differentials.
Oh, that's in the pay gap report, which comes later in the year. That's right, that's different, yes.
Okay, we now have the questions. The board are asked to receive a report of assurance. It is significant assurance based on the process rather than the outcome. Are we happy the board to accept the recommendation? Yeah? Okay, thank you. Can we then move on to these Digital and Estates Committee Chair's report?
Yes, you are here. Yeah, as Emma's not here today, Chair, perhaps we just take away any questions and take it to the next meeting.
Yeah. Have you any questions, or do you want to email them in? Any questions in relation to Digital and Estates Committee Chair's report? No? If you realise after the meeting that you have questions, if you can just email them, I'm going to read that to them. You can send them over to follow up with them, Emma. Okay. Next item on the agenda, the audit and also committee's chair will hand over to Brian.
We've given a verbal for in this committee.
Oh, I missed you altogether.
Well, many do, Jan, many do.
I do apologise.
You can take me off as well if you want. So look, in the interest of fun, we'll flesh it out this afternoon if we need to, but just a few points. We approved the AWP internal operating plan within committee last Friday. And as part of that, we also discussed the frequency and format of ongoing reviews of the operating plan so that we can get assurance at various points throughout the year. My question to Dominic earlier was a bit preemptive because we did discuss kicking off the savings plan for 26-27 within the Finance Committee and what format that might take. We reviewed what was the month 12 end of year finance report and commended the finance team on many positive outcomes. And we heard the update from Matthew. Matthew gave the good progress made with talking therapies early on as part of his report, but there were no alerts this month in terms of operating performance. I think that covered it for now.
Any questions for them? Thank you, Paul. Now, can I hand to Brian?
Thank you again, Chair. Yeah, take it as read. Just to bring your attention of the board to the first two items on the alert. We approved the current plan from external audit, which is to bring everything to fruition by our next board meeting on June 23rd, which will follow assurance from Audit and Risk Committee. We've also improved the internal audit and the counter for 25-26. Just to note, technically it's the draft head of internal audit opinion. There's 4 possible assessments that head of internal audit can give us. Basically, they're 2 over the line, which are green and amber green, and 2 below the line, which are obviously amber, red and red. If you remember, 2 years ago, we were below the line in terms of assurance. But again, this year, as per last year, draft head of internal audit opinion is that we do have an adequate and effective framework for risk management, governance and internal control. And the next sentence is a standard requirement of that internal audit feedback. So good news that we are over the line for governance, risk management and internal control.
Thank you. Thank you, Brian. Any questions for Brian? No? Okay. So then we will move on to the finance report, month 12. James.
Yeah, thank you, Chair. I will take the paper as read, particularly as there are no surprises in month 12, which is a really good position to be in. So I'll just go through the key highlights, which are that we did end month 12 and the year with a 0.1 million surplus. So we achieved our overall financial governance, which is a really strong position to be in, given the overall landscape of finances across the UK, I would say. Efficiencies also returned to what we expected. So we had a 93% current delivery for the year, which is also very positive. And cash was ahead of plan. It was 25.6 million at the end of the year, but it was in line with our latest forecast, which we were predicting across the year. I think the big positive for us was that our capital expenditure ended the year at 7 million against a plan of 27.8. So that was a significant improvement in month 12. And thank you to all the estates team for helping us to achieve that, which is very, very positive indeed. And finally, just to note that we continue to retain our very positive position on Better Payment Practice Code, which means that we are paying our suppliers ahead of where we need to, which is very positive indeed.
Thank you. Questions?
Just a quick comment, if I may. It's always refreshing ahead of an audit and risk, but when the finance team in December are forecasting to hit the target year and they do actually achieve it, unlike a number of other trusts that have the pleasure of working with for some time. So congratulations to the finance team, not just for what they did last year, but for what they continue to do up until the finish date for audit, which is pretty soon.
Yes, so the accounts will be signed off on the 23rd of June.
And for all the work they're doing, particularly with external audit. I know keep them very much on the toes with lots of detailed questions. And also to add my thanks, because I was getting a bit worried about capital expenditure in month 11. Fantastic achievement in month 12. So as James said, congratulations both to the finance team for processing and also the statesman.
Thank you, Brian. Thank you. Any other questions or comments? No? Okay, we're asked to note the year-end position. That's it. So we'll have to note the position.
Very happy to read some.
I think we've done a fantastic job of the team have done it. Also, I think operations have done a good job in enabling people to pull together the sticks and to deliver the sticks. So I think that there's some congratulations all around. I think. Thank you. All right, the next paper, the operational plan. So it's you again, Jennifer.
Yeah, I think this is just to really bring us to a conclusion on our planning for 25-26 and provide assurance to the board that there's a significant amount of triangulation that we've come to. So through finance, we submitted the draft plan in March and changed very little to when we submitted the final plan to NHS England in the end of April. So really the triangulation goes to our system and to BNSFG, where we report through to make sure that our alignment with them is correct, and then through workforce and income internally, and then operationally, obviously, as you can see through the assessment through the paper, to make sure that everything really does triangulate and provide us with a strong plan going into 25-26 to give us our best opportunity to deliver what we need.
Thank you. Any questions? Brian?
Just had one quick observation, if I can find the right page. I think it was under bullet point 11. I think this is just wording when we talk about professional experience and PPREF. Presumably we want to increase experience and outcomes for all people, not just those from minorities.
Would you?
Specific.
Oh, okay. Yeah, that's the way it was written. Yeah. Yeah.
Thank you.
Yeah.
Yeah.
Yeah, thank you for pointing out the obvious. I stay for it.
Thank you. Thank you. Again, the service user and care expert by experience group were very interested in the operational plan and could see some of the themes from their own lived experience coming through there that they were keen to highlight to the board. So some of the work under our strategic objective for clinical effectiveness around the AWP community programme, particularly thinking about the front door of the service and working with GPs, and reflected on often difficult experiences that our service users and carers have at the front door of services, both with GPs, but also in terms of accessing either AWP services or services via voluntary care sector organisations as well. So they were very keen to emphasise the importance of that no wrong front door approach and their own lived experience reflecting what we were doing within the operating plan as well.
Thank you. Thank you, Vanessa. Any other questions or comments? No? Okay, in terms of this paper again, we're asked to approve the internal operating plan and note the changing landscape in 25-26, which will require an agile approach to the plan or could require rather than will, could require an agile approach to the plan in year. Are you happy to accept those two recommendations? Okay, thank you. Right, we have papers for information. Chair's report. That's one. The learning from desk Q3. I'm going to read that. Is there anything that you want to raise with in terms of that paper? Sarah?
No, Chair, thank you. That has been through CEOG and also through QNS, so has been scrutinised by those committees.
Are there any questions in relation to the learning from desk course 3 paper? Bearing in mind that it has been through 2 other committees and scrutinised. Any comments, questions? No? Okay. I'll move on then to safer staffing report. And again, it's paper for information, but there may be questions that we wish to raise with Sarah, the direction, nursing and quality. Is there anything you want to say related to the paper, Sarah, before we open it out?
No, not specifically. Again, I would echo in some respects the report into the learning from deaths in that this report has been scrutinised by the Safe and Effective Staffing Group, by the Effectiveness and Experience Oversight Group, and by the Quality and Safety Committee.
Thank you. Any questions or any comments? I have had a question. Just curiosity in relation to Hazelwood, because that was the only one that I could see through the report that required increase in staff, and it was a healthcare support worker, I think, but just requiring it. I just wondered whether you were, where it left us.
The work that we've been doing for Hazel Ward, so safer staffing is reviewed through use of the mental health staffing optimisation tool, MHOST tool, and a data collection from that. In addition to that, we use clinical judgment and a range of quality and safety metrics as well. MHOST tool may indicate an increase in staffing, but you would want to see that over a consistent period of time before you increase substantive staffing. As it may be that there is a temporary blip in increased acuity and dependency on that ward. We have seen a consistent increase on Hazel Ward, which is why it's flagged in the paper. We have looked at the increases that we've seen over time in use of enhanced therapeutic observations on that ward, or kind of 1-to-1 or 2-to-1 levels of observation. And that is what is driving that increase in staffing use. We did some work with the team to look at processes and procedures around that, and I did not flag any particular issues. However, we are launching a piece of work with all of our wards to look at the clinical management of enhanced observations. And so we would like to complete that before we would recommend a substantive increase for the team. We did discuss this issue in quite a lot of depth at the Quality and Safety Committee, and in particular, reflecting the staff's lived experience on the ward is that they do see that they need an increase in they feel they need an increase in staffing. But we would also like to do some benchmarking with other psychiatric intensive care units nationally, as we know that overall with safer staffing, we do benchmark quite well, and we benchmark high, which is a good thing. So we want to do that first. The mitigation whilst we do that work with Hazel Ward is that they are able to increase their staffing levels based on the individual needs of the service users on the ward without any kind of recourse, if you like, to having to go through the safer staffing process. So on ad hoc basis, if they need more staff, they can use more staff. We are continuing to monitor their actual usage as well versus their safer staffing level, and we will bring back a further analysis of that in the next safer staffing review.
Thank you. Thank you, Claire. Any other questions or comments? No. Okay. The recommendation is that we know the findings and the oversight processes that are in place. We'll have to accept that recommendation. Great, thank you. All right, and finally, or not, almost finally, the Research and Development Annual Report. Now again, quite a lengthy and interesting report from Julian. Sponsor Sarah, is there anything that you want to add to the sale, Constantine?
No, nothing specific to add. I would recommend people look at it. It's interesting, and there's a lot of work going on, but no, I don't have anything specific.
Thank you. It comes to quality and safety as well. And one of the things we noted in the report was that they took the advice of Brian, who provided them with feedback on their last report and added some examples in.
Not the hand on the graphic. Just for you.
My feedback previous 2 years was, in fact, it's a bit boring. But on a serious note, can I congratulate the R&D team, because the number of projects and grants and trials that they're now working on is fantastic, and they're really building a reputation. A number of board members were at the annual R&D conference last month or whenever it was, and having guest speakers coming down from the work that we're doing is absolutely great. And it is also linked in. I understand that the National Institute of Health and Care Research is putting quite a big chunk of money into developing research in primary care. And that might be an opportunity for ring-fenced funding, what we say there, to actually increase the R&D activity. And I think a lot of people's first interest, if you like, in mental health well-being is through primary care. So it'd be interesting to see how that leads.
Thank you. The recommendations of this paper then are that we note the annual R&D report. Secondly, that we recognise the contributions made to the trust and to the wider national research agenda. And finally, that we as a board and as an organisation continues to support the embedding of research projects and ongoing support for the positive research environment. And the catchphrase at the end, research is everybody's business. Do I have agreement with those recommendations? Yeah? Okay, thank you very much. And again, great job by Julie and his team. Small team, but they do a phenomenal job. So thank you to him. All right then, so any urgent business? I'm just looking around the table. No. In that case, I am going to conclude by drawing this part 1 public meeting to a close. The board will this afternoon will meet in private for a section to the business that is not necessarily public at this time. So thank you very much everybody for your contributions. The board meeting is now closed.